Dear students, welcome on our lecture course. The topic of our today's lecture is clinical, laboratory and instrumental method examination of the basic syndromes, digestive system diseases. We'll stop on the characteristic main syndromes which are characteristic for gastrointestinal tract and liver pathology. If we are talking about basic syndromes of the patient with stomach and intestine diseases, first of all, we'll stop with you on characteristic of abdominal pain, gastrointestinal bleeding, dyspepsia, disturbance of gastrointestinal tract motor function, irritative bowel syndrome, and malabsorption. Abdominal pain. Patient come to you with pain into the abdomen. To differentiate any type of pain and find its origin, we must remember abdominal pain may be visceral origin, which appears due to affection of inner organs. It may be parietal origin, which indicates acute surgical situation because involvement peritoneum in pathological process. It may be a referred origin. We must remember about psychogenic origin of abdominal pain and extra-abdominal origin. Let's stop on the characteristic that I can help you to differentiate any cause of abdominal pain. Visceral pain appears due to spasm of non-strained muscles of hollow organs, stomach, intestine, gallbladder. It may be caused by sprain of the hollow organs wall and tension the ligamentous apparatus. You know that every organ holds a definite position due to action of a ligamentous. Other cause of pain is sprain of the parenchymatous organs capsule. Such types of pain is characteristic for liver and pancreas. Ischemic or stagnant circulatory injury in the abdominal cavity vessels due to the spasm or obstruction. Usually, it appears as complication of the patient with atherosclerosis, may be result of thromboembolism and needed acute surgery action. And we must remember about structural changes of the organs injuries. What is characteristic of visceral pain? First of all, it is characterized with definite position and 80% irradiate in other sides of abdomen. It's tightly correlated with eating or defecation, and depending of specific characteristic, we can differentiate pain from different abdominal organs, on which we'll stop slightly later. Parietal pain. If we are talking about parietal pain, usually it has definite location. It's accompanied with vegetative symptoms, other word symptoms which not connected with pathology of digestive system. And it's intensified, accompanied with increased fever, and must pay attention of the doctor on any acute situation. A referred pain appears due to crossing innervation of abdominal organs, and sometimes patients with liver diseases except complain on classical pain in right hypochondrium, feel pain in the abdominal center. Patients with stomach diseases sometimes feel pain behind the sternum if the source of pathology localizes in cardiac part of the stomach. And some abnormal characteristic, especially location of pain, may be due to crossing innervation and sometimes may have not typical clinical manifestation, which needed deep knowledge of the doctor and sometimes long time for establish of disease. Psychogenic pain. No, first of all, it is characterized with very rich clinical symptomatic, sometimes not tightly correlated with affection of digestive system. Patient complaints may change anytime. First of all, he can complain pain in any side of abdomen. After some days, other sides of abdomen or pain displays in other part of the body. And it's very rich with psychogenic symptoms. Patient very active. Sometimes his behavior not correlated with objective symptoms, which must pay attention on possible uh, cause of psychogenic origin of pain, and this patient needed specific sedative or sometimes any other specific psychogenic helpness. And extra abdominal pain also is caused due to crossing innervation, and sometimes patient with kidney pathology except pain in lower region can complain of the pain into the abdomen, and doctor can go to false way for diagnosis, losses time, and only later clear true disease. To help yourself and establish disease in time, because from the true diagnosis will be dependent result of our treatment. When the patient complains on abdominal pain, we must ask him depending of definite order. You see main questions which you are needed to clear. I'll not stop to every questions because will be practical classes on which we more completely will talk about all pathology, but I'll pay your attention. Any abdominal pain obligatory needed to describe its position, radiation and character. Then obligatory clear specific aggravating and relieving factors. And if we are talking about digestive system, we must clear correlation of pain with eating or defecation. Such 5 questions helps you to differentiate pathology of different digestive organs. I'll very fast remember you main characteristic of abdominal pain, which are typical for different organs affection, but you before exam you must come back to preceded lectures when we gave more full characteristic of every digestive organs. And first of all, I'll again remember you our topographic characteristic of abdomen, and you see, if you compare two pictures, you see dependent location of pain, doctor can start from examination one or other abdominal organs. You remember that first of all abdomen divided on 3 parts with horizontal line, epigastrium, meso and hypogastrium, and then we'll add 2 vertical line, and every area divided on 3 parts. Let's remember specific characteristic of stomach pain. No, first of all, classical location of pain is epigastric region or upper part of abdomen. It may be epigastria propria or whole epigastric region. Usually, stomach pain irradiates backward in spinal cord due to its specific innervation. And as stomach hollow organs, pain may be spastic or distensional character and tightly correlated with eating. Patient feels pain on hunger stomach or after eating. And we can pay attention on specific posture of patient. Fourth posture, patient with stomach pain can slightly decrease it when he inclines upward because stomach innervated with solar plexus. Intestinal pain has same character with stomach because it's also hollow organs. But we must differentiate problem with small and large intestine depending location of pain. Small intestine pain localizes in the center of abdomen, umbilical region. Large intestine pain localizes on lateral part of abdomen along course of large intestine. And problem with transverse colon sometimes resembles stomach abdominal pain and needed more attention of the doctor because if the intestinal pain not tightly correlated with eating, mainly with defecation, problem transverse colon tightly correlated with eating because due to pressure of the stomach after eating, patient feels discomfort in upper part of abdomen, same location with stomach, which needed more attention of the doctor and more long differential diagnosis. Gallbladder. Patient feels pain in right hypochondrium nearest right eighth of rectus muscle and it can show point of pain due to anatomic position of gallbladder. Usually pain irradiates upward to the right and as any hollow organ may be spastic or distensional character. Pain provoked by jolting movements, physical exercise, eating of fatty food, and disappears after using of hot water bottle, which patient can put on gallbladder, especially in its spastic character. Liver pain also localizes in right hypochondrium, but it's more diffuse and, on contrary from gallbladder, has dull, boring character because liver is parenchymatous organ. Pain irradiates upward to the right, has same provoke fractures as gallbladder, and sometimes warm procedure also can help the patient because stimulate blood flow and slightly diminish capsule of the liver and but its diffuse character and more diffuse location help differentiate liver and gallbladder pain. Pancreatic pain localizes upper part of abdomen, sometimes may be mixed with some stomach and transverse colon pain, but on contrary from these organs, it may be boring character, spastic character not characteristic for pancreas, and due to specific innervation, pancreatic pain obligatory accompanied with irradiation of pain upward to the left and along hollow trunk. Other word has specific Godlin character and specific posture of patient helps the doctor in diagnostic way. Next slide demonstrates you specific Godlin character of the pancreatic pain which helps you differentiate it from stomach and transverse colon. I'll pay your attention on dangerous symptoms. which help differentiate the visceral and parietal origin of pain, and pay attention of doctor on necessitated surgery aid and or sometimes specific diagnosis. When we must pay attention on this symptom, when the abdominal pain accompanied with giddiness, progressive weakness and apathy of the patient, accompanied with non-specific digestive symptoms such as decreased blood pressure and tachycardia, because which is response of vegetative nervous system, when we'll see visible hemorrhage, bloody vomiting, hematemesis, or bloody defecation, when pain accompanied with fever, it's intensified during short time, pain accompanied with a repeated vomiting which doesn't help to relieve pain. We must pay attention on the passage of gases and peristaltic sound, obligatory auscultation of abdomen. If we see that pain intensifies, accompanied with exhaustion of the abdominal muscles, which may be clearness during superficial or deep palpation, and checking specific Mendel or Schotten-Bloomberg symptoms. Defecation can accompany with syncope. All these symptoms must pay attention on possible acute situation. We are talking about acute abdomen, and this patient needed surgical attention. Principles of diagnosis. Any patient which enters in hospital obligatory exam with blood and urine resistant, because there are routine examination. Biochemical tests especially needed for diagnosis liver, gallbladder and pancreas pathology. If we see about involvement stomach or duodenum, we'll send our patient on esophagogastroduodenoscopy. Patient with pathology biliary tract, gallbladder, liver, pancreas needed ultrasonographic examination. If we see about possible acute obstruction of intestine, we'll send our patient on X-ray examination. Maybe use computer tomography, especially if we seen about new growth and can check other organs on metastasis. Every patient with abdominal pain must be examined with electrocardiography. We remember about a typical characteristic of myocardial infarction, abdominal variant of myocardial infarction. And woman must be examined on the pregnancy-specific diagnostic test, because maybe it's a typical location. Each is principles diagnosis of the patient with abdominal pain. Next syndrome on which will stop gastrointestinal bleeding from the digestive apparatus, and first of all we must differentiate bleeding from upper or lower section of gastrointestinal tract. More often causes of gastrointestinal bleeding, it is rupture of varicose dilated vein of esophagus, or specific rupture of esophagus due to Mallory-Weiss syndrome. We must remember about acute hemorrhagic gastritis and peptic ulcer of the stomach. Canceromatous process often accompanied with bleeding. Problem with small intestine, Crohn's disease, or large intestine, non-specific ulcerative colitis. We must remember about diverticulosis or neoplasm of the intestine, and some anorectal diseases may be source of gastrointestinal bleeding. And depending on location of bleeding, it may be easy or more difficulty diagnosis. First of all, we must remember where is border between upper and lower section of gastrointestinal tract. From esophagus to lower part of descending colon, upper section. It is problem with esophagus, stomach, duodenum, small intestine, and large intestine before its descending part. Lower section of gastrointestinal tract starts from descending bowel and finish in anal canal. We must remember about this location because manifestation of bleeding will be different. And we must remember about some other pathology which can accompany with gastrointestinal bleeding but needed other principles of treatment because it's connected with cardiovascular pathology, some systemic diseases, or hemorrhagic diathesis, or some blood diseases about which we will talk during next lectures. Which is manifestation of bleeding from upper part of gastrointestinal tract. If the source of bleeding into the stomach or esophagus is manifested with hematemesis, bloody vomiting. But we must remember, if the vomiting appears immediately after bleeding, we can see fresh blood and patient immediately call the doctor. But if the vomiting appears later, due to destruction of erythrocytes, except fresh blood, we can see specific brown, or we are talking about coffee ground of color of vomitus. And patient unknown that brown color may be a result of bleeding and usually go to the doctor later, or doctor must ask the patient additionally and pay his attention on the color of bleeding. Way of the evacuation of blood not long, and I'll remember you, if the vomiting appears immediately, we can see fresh blood. But if the bleeding not accompanied with vomiting, blood go downward, and see please, before it's go to anal canal and finish with defecation, blood goes 5-7 meters and cannot be seen as fresh blood. We can see black color feces, which is called melena, but when we'll ask the patient about black feces, we'll pay attention. It must be black, not dark, to differentiate with pseudomelena, and obligatory ask the patient about taking of medicines which also can give false black color of feces, especially there are medicines with iron, with bismuth, which can simulate black feces, but it's not connected with bleeding, and it is called pseudomelena. A lower section bleeding manifested with visible blood, bloody defecation, because way of the blood very short from lower part of descending colon to anal canal, and it's early diagnosis before the complication. If the blood invisible, no fresh blood, usually patient go to the doctor later with complication of the bleeding. Other words, with symptoms of anemia, because he becomes weak, he cannot do his work usually. Sometimes he feels giddiness, syncope, fear, nausea, hearing and vision decrease in long standing latent bleeding, especially from small intestine or upper part of the large intestine. On examination, we can see that skin of the patient is pale, sometimes maybe lip cyanosis due to decreased level of erythrocyte and disturbed gas changing and transport of oxygen to the tissue. Extremities of the patient may be cold. Sometimes we can see clump with sweat during touching. Patient predilected to yawning and will reveal low blood pressure and rapid small pulse as a compensation of hypoxia. But I'll again remember you, there are symptoms of complication, symptoms of post-hemorrhagic anemia. Basic signs of bleeding I named you earlier. Next step, which is additional diagnostic method, and first of all we'll send of the patient on blood test to reveal signs of post-hemorrhagic anemia, and then we'll find source of bleeding, and any patient with anemia obligatory start examination from examination of gastrointestinal tract, which is esophagogastroduodenoscopy for esophagus and stomach, double balloon endoscopy for and capsule endoscopy for small intestine, X-ray examination or colonoscopy and proctosigmoidoscopy for large intestine. And if all this examination doesn't reveal pathology, we can send patient on arteriography, because if you remember, I said you source of bleeding may be connected with pathology of cardiovascular system, some systemic and blood diseases. You see our patient with bloody vomiting due to rupture of dilated esophageal vein as complication of portal hypertension. Such rupture of esophagus is characteristic for Mallory vein syndrome. Such vein is characteristic for portal hypertension. For diagnosis, we'll use gastroduodenoscopy and easy find source of bleeding into the stomach or into the esophagus. Double balloon endoscopy or capsule endoscopy helps reveal source of bleeding into the small intestine. And proctosigmoidoscopy or colonoscopy helps reveal source of bleeding in lower section of the large intestine. You see source of bleeding in ascending colon, which was revealed with colonoscopy. Dyspepsia syndrome is characteristic for the problem with stomach, and first of all problem with time of digestion and time of evacuation of the food from the stomach. Patient complains of uncertain pain or discomfort in epigastric region after eating, because he feels heaviness, overflowing of the abdomen after eating. And patient pay attention, I'll take small pieces of food, result as I'll take a lot amount of food. Doctor reveal abdominal distension if the patient will be examined immediately after eating. Patient can complain of regurgitation or eructation. Sometimes it may be revealed and audible on distance. Patient feels nausea. All these symptoms, I'll remember you, appear due to decreased activity of the stomach, usually stomach hypersecretion, and decrease its motor function, because food delayed into the stomach and slowly digested. First of all, we'll clear unspecified dyspepsia. It will be our primary diagnostic opinion, which must be obligatory clearness because dyspepsia may be functional or organic origin. Functional due to disordered innervation of stomach, organic due to true anatomic defect of the stomach. Let's remember pathogenic mechanism of dyspepsia. No, first of all, I said you it is decreased secretion of the gastric juice and decreased activity of hydrochloric acid and pepsin. Motor dysfunction due to disordered innervation. Usually there are functional disorders which may be regulated with some medicines. We must remember about Helicobacter infections, which is source of inflammation and anatomic defect of the stomach, structural modification, aseptic ulcer or new growth. Stomach tightly connected with activity of nervous system, and we must remember about some psychological factors which is source of some disorders of gastric secretion and motor function of stomach. And we must remember about some specific visceral hypersensitivities which are provoke factors of stomach function disorders. And depending on source of dyspepsia, we use one or other medicines, which you will more completely study on the specific cause of gastroenterology. But we must remember about diagnostics ways because main purpose of our cycle is principles of diagnosis. I'll again remember you about blood tests which help differentiate functional and organic source of patient discomfort. Sometimes we are needed biochemical tests to differentiate true pathology of the stomach or functional disorders because the primary affection of surrounding organ. Respiratory tests widely used to reveal Helicobacter pylori infections. This is a comfortable method which hasn't any contraindication. We must remember about endoscopic examination of the stomach with obligatory pH metry, which helps assess functional activity of the stomach. Simultaneously, we can examine Helicobacter pylori, and sometimes we'll send our patient on ultrasonography. I'll remember you about crossing innervation and sometimes primary affection of surrounding organs manifested with stomach problems. Stomach motor dysfunction, which appears due to prolonged or sometimes impossible evacuation of the food from the stomach into the duodenum due to pyloric stenosis, which appears due to organic pathology. It may be abnormal post-ulcer growth of the scar or growth of the scar after chemical injury. We must remember about canceromatose process which obstruct pylorus and completely stop evacuation of the food from the stomach. And functional disorder, we are talking about abnormal pyloric spasm, which appears as complication of peptic ulcer and edema of the pylorus. It may be result of hyperacidic gastritis and often accompanied with any neurosis because its source is neurological disorders. But primary. In any case, patient feels discomfort after eating, pain or distension of the abdomen, feeling of heaviness after meals and fat satiety. Doctor reveal abdominal distension. Patient can feel regurgitation and eructation, which accompanied with nausea and vomiting. If you was attentive, first symptom resembles symptoms of dyspepsia, but we doesn't say about vomiting and drowsiness after meal and weight loss. New symptoms which indicate that patient feels problem with evacuation of the food from stomach, especially it is characteristic for organic problem, for pyloric stenosis, when the food doesn't have any other way of evacuation except come back through the mouth. Until you understand, if the patient take food but food doesn't completely digest it and absorb, its effect zero. And after some time, due to taking all deposited elements, patient progressively loses weight, which must pay attention of the doctor. It's not usual dyspepsia. It is more severe problem which needed other method of treatment. Diagnosis. No, first of all, in disordered motor function of the stomach, especially in pyloric stenosis, can reveal some symptoms in inspection because distension of abdomen and palpation. We can palpate dilated stomach. X-ray examination show you level of obstruction, and gastroduodenoscopy helps reveal each is complication of severe peptic ulcer or each is new growth which needed other way of treatment. On X-ray examination, you see level of obstruction because growth of tumor and narrowing of pylorus. Next syndrome, irritative bowel syndrome, is characteristic for affection of large intestine, but I'll pay your attention, it is functional disorder which may be established only after excluding possible organic affection of large intestine. Main symptoms with which patient go to the doctor is abdominal pain, which obligatory accompanied with disordered defecation, constipation or diarrhea. Both these symptoms must be not less than 1 time per week and prolonged 3 months from last 6 months. In this case, we can think about possible irritative bowel syndrome. It may accompanied with palpitation after defecation, appearance at the same time with change of defecation rate, or same time with change feces shape and consistency. Other word, it is characteristic of defecation. Because I'll again pay your attention, main signs of irritative bowel syndrome, it is abdominal pain accompanied with disordered defecation. And I'll pay your attention. Pain whenever occurs at night and disturb sleep of patient. Doctor obligatory must ask the patient about this problem because it helps you differentiate organic and functional disorders. If the pain intensifies or appears at night, disturb patient sleep, it cannot be functional disorders. Otherwise, it's not characteristic for irritative bowel syndrome, and we must find organic origin of pain. Let's stop on characteristic of defecation. First of all, we'll obligatory ask the patient about time of defecation. It may be rare or often. Consistency of feces, hard or liquid, sometimes completely watery. Problem with defecation when the patient needed excessive force, when the patient doesn't feel comfort after defecation, or patient needed sudden defecation, sometimes cannot prevent defecation, and you understand will be some problem for walking activity. Patient cannot go out from home because he must be nearest sewage. And depending on all these characteristics, we can differentiate patient predilected to constipation or diarrhea. If our patient predilected to constipation, usually feces are hard, difficulty evacuated, and defecation rare odor. But main characteristic of constipation is consistency of feces, hard consistency of feces. If our patient predilected to diarrhea, his feces will be liquid or watery. Patient defecate more often, maybe sometimes per day, and sometimes feel sudden urge to defecate. But I'll again pay your attention. Main differential sign between constipation and diarrhea is consistency of feces. Auxiliary symptoms which may accompany of main signs of irritative bowel syndrome, which is excretion of large mucus together with feces, abdominal swelling due to meteorism, rumbling in the abdomen, especially if patient predilected to diarrhea, and irritative bowel syndrome as any functional disorders very rich with accompanied psychogenic symptoms, symptoms of vegetative disorders or other functional gastrointestinal tract diseases, especially irritative bowel syndrome often accompanied with functional dyspepsia, which pay attention on possible functional origin of disease. What is cause of irritative bowel syndrome? Now, first of all, it is motor dysfunction of large intestine. You'll understand if the motility of large intestine decrease, feces long time holding to the intestine, water completely absorbed, feces becomes hard, difficulty evacuated, and patient feels some discomfort during or after defecation. We must remember about splanchnitic sensibility disturbances, non-adequate response of large intestine. We must remember about disordered central nervous system regulation and some psychopathological disturbances. Last time we'll said about tightly correlation between activity of the central nervous system and motor activity of large intestine, other words, brain intestine vein. Oftenly, irritative bowel syndrome appears of the patient with preceded infectious diseases of intestine. For reconvalesation, this patient sometimes needed half year or more long time. We must remember about possible dietary allergy because we'll use food sometimes which very rich with antibiotic or other chemical substances, or provoke factors may be some external or internal trigger factors such as stress, antibiotic meal, or dysbacteriosis, which appears as complication, prolonged antibiotic therapy. You know that our patient predilected to independent treatment and can take any medicines independently without doctor prescription. Clinical classification irritative bowel syndrome is based on characteristic of feces. For this purpose, we'll use Bristol scales. You see different shape of the feces, and depending of its characteristic, we'll classify irritative bowel syndrome on three groups: irritative bowel syndrome with constipation, with diarrhea, or mixed when the period constipation alters with period of diarrhea. Principles of diagnosis based on exclusion organic pathology of large intestine. If you remember, I'll start my characteristic of irritative bowel syndrome from the words "it is functional disease which may be established only after exclusion of any organic pathology," on which shows red flag symptoms. First of all, we must completely collect all complaints of the patient and anamnesis. And if we reveal complaints of unmotivated weight loss, ninth symptoms, intensive abdominal pain, age of the patient, and compromised history. If the parents of the patient was sick with any canceromatous diseases, for example, or any organic pathology. Result of physical examination, fever, and any abnormal symptoms which was revealed during palpation of intestine, or abnormal enlarged abdomen and its asymmetric protrusion. Result of laboratory test, blood and feces analysis indicates about possible organic pathology. Functional disorders were never accompanied with these symptoms, but it's very rich with some additional vegetative nervous system or psychic disorders. Principles of diagnosis is based on the Roman criteria, which will be changed in 2016 year, and Bristol scale are the word characteristic of feces. And I'll again pay your attention on patient age. Functional disorders not characteristic for senile people. Duration of disease. You remember I said you symptoms not less than 1 times per week and 3 months during last 6 months. We'll pay attention on laboratory research, blood, urinary, biochemical, and feces analysis. Obligatory will examine feces on deep-seated blood, and instrumental examination. Obligatory examination of large intestine with colonoscopy, proctosigmoid, or X-ray examination. But more optimal colonoscopy because it helps examine all large intestine and exclude any organic pathology, after which is possible disease irritative bowel syndrome. You see anatomic changing of large intestine on X-ray examination, which reveal growth of tumor. We remember about diagnostic value of colonoscopy, which is normal and pathological wall of large intestine. And last syndrome, on which I'll stop on examination of the patient with gastrointestinal tract, which is malabsorption syndrome which appears due to pathology of small intestine, because small intestine is part of gastrointestinal tract which control absorption of digested food. Different pathology of the small intestine, or its dysbacteriosis, or deficiency of the enzymes, or some problem with circulatory activity can disturb absorption activity of small intestine. And we must remember about pancreatic insufficiency, because first of all, food must be completely macrodigested, which is possible due to activity of pancreatic enzymes in duodenum. After that, due to specific anatomic structure of small intestine, and after microdigesting into the village, food must be absorbed and all elements may be used with our organism. If this process is stopped, patient will be diagnosed with malabsorption syndrome. Clinical manifestation, first of all, it is diarrhea, early weight loss, as result asthenic syndrome, because will be disturbed all metabolic process, and in prolonged development of malabsorption we can reveal different accompanying complications due to deep metabolic disturbances, such as disordered fatty, carbohydrate, protein, vitamin, and microelement metabolism. Disordered fat metabolism manifested with progressive loss of weight and hypercholesterolemia. You remember, cholesterol needed to normal structure of cells wall, cells coating, will be disturbed absorption of liposoluble vitamin, and first of all, it is vitamin D and E, and as a result, fatty hepatosis. Carbohydrate metabolism disorders manifested with hypoglycemia, and as a result, decreased activity, decreased working capacity because deficiency of energy. Protein metabolism manifested with hypoproteinemia, as a result decreased oncotic pressure and uncontrolled resistant edema. Water salt disturbances manifested with hypokalemia, hyponatremia, calcemia, which first of all manifested with disordered heart activity, different types of arrhythmia and heart block. Hypophosphatemia manifested with problem of bone structure. Deficiency of iron manifested with iron deficiency anemia, and different problem with tissue irons, about which we will talk with you on the next lecture, and progressive hypopolyvitaminosis, which manifested with problem oral cavity, fissures in angle mouth, dry mucus, problem with gums, progressive caries, and any other symptoms which you can remember, because you know activity and function of different vitamins in our life activity, from physiology, from biochemistry. We examine oral cavity and pay attention on tongue, because tongue is glass of activity gastrointestinal tract, and we can reveal pellagrous or atrophic glossitis. We can reveal deficiency of hair growth, problem with nail due to progressive iron deficiency anemia, and heavy degree of malabsorption, sometimes needed action of other doctors. First of all, dermatological attention due to formation of dry hyperkeratosis, pellagra, eczema. Patient feels problem with gait, problem with memory due to neurological encephalopathy, predilection to convulsion because deficiency of some micro elements. manifested with depression of endocrine function due to hyperadrenochromaticism, pituitary insufficiency, hypothyroidism, low heart rate, low blood pressure, low vital activity. Diagnosis will start it from blood test and different biochemical examination, obligatory feces analysis, test with dexylose, which can show abnormal bacterial growth into the small intestine, which is hydrogen of respiratory test, and double balloon or capsule endoscopy helps examine mucus of small intestine to reveal organic pathology, and if possible we can take small intestine biopsy, but you'll understand usually it is possible only due to operation. Usually it appears casually because patient enters in hospital with acute abdomen due to rupture of the small intestine wall or progressive bleeding. Next part of our today's lecture, it is liver syndrome. We know that liver is vital organs and it's very rich with clinical manifestation. But today we'll stop only on main liver syndrome such as jaundice, portal hypertension, cholestasis, and hepatic insufficiency. I will start from jaundice syndrome, which manifested with yellowish color of skin and mucus, obligatory, especially it is needed for patients with dark skin, and it helps you differentiate true and false jaundice. And you remember that we distinguish three types of jaundice: hemolytic or suprahepatic, parenchymatose, true hepatic or hepatocellular jaundice, and obstructive subhepatic jaundice. To talk about jaundice, I want to remember you physiological or the formation of bilirubin, because jaundice appears due to hyperbilirubinemia. Physiologically, bilirubin is formed due to destruction of erythrocyte in reticular endothelial system. As a result, will be formed unbound bilirubin, which not water soluble and can circulate only into the blood and can be revealed only in blood test. Unbound bilirubin transported into the liver, where due to action of glucuronic acid, itself change its structure, becomes water soluble, and we are talking about bound bilirubin, which together with bile enters into duodenum and go along the gastrointestinal tract, along the intestine, and removed with feces. But if the bound bilirubin water soluble, it may absorb into the blood and may be removed through the kidney. As a result, our urine has light yellow or straw yellow color. Normally, in blood will reveal two forms of bilirubin: 75% unbound and 25% bound bilirubin, because we remember bound bilirubin physiologically together with bile enters in duodenum, where from bound bilirubin will be formed its next form, urobilinogen, which absorbed into the blood and come back into the liver. And normally urobilinogen cannot be revealed in any specimen. Other parts of bilirubin into the large intestine will be transformed in stecabilinogen and stecabilin, which gives specific brown color of feces. But we remember bound bilirubin and all its structures water soluble, and along all transport way portionally absorbed into the blood, and blood go through the kidney and will be removed with urine. We are talking about urobilinoids, which normally slight amount presented in urine. We decide that urine is free from this element and has normal straw yellow color. In case of hemolytic jaundice, which appears due to abnormal destruction of erythrocytes and manifested with hemolytic anemia, or it is characteristic for patients with B12 folic deficiency anemia because abnormal megalocytes easy destroyed into the capillaries network because not correlated with diameter of capillaries. Hemolytic jaundice is characteristic for the patient with malaria and protracted septic endocarditis, but the cause is abnormal destruction of erythrocytes. As a result, blood overfilled with unbound bilirubin, which enters into the liver, but activity of hepatocytes not enough to transform all unbound bilirubin into the bound. As a result, common bilirubin in blood increases mainly due to its unbound form. Bilirubin usually go along gastrointestinal tract with formation of urobilin, which cannot come back into the liver because liver overloaded with transformation unbound bilirubin into the bound. As a result, all urobilin absorbed into the blood and will be removed with urine. As a result, urine has specific dark green color. Other part-bound bilirubin go into the intestine, but its amount also increases because activity of hepatocyte increase. As a result, feces has more dark color due to increased level of stecabilin, which also absorbed into the blood, which gives dark color of urine. Patient complains first of all on weakness and giddiness because it is result hemolytic anemia, which is main cause of hemolytic jaundice. Patient can feel discomfort in right and left hypochondrium. Right due to activization of liver and its slight distension, enlargement, and left due to activization of spleen, because you remember spleen is the depot of all destroyed blood cells. We remember that urine and feces of the patient becomes dark because active absorption of different forms of bound bilirubin, urobilin, stecabilinogen, and stecobilin. Skin will specific lemon yellow color because combination of jaundice and anemic skin. On percussion and palpation will reveal hepato and splenomegaly. Parenchymatous hepatic jaundice appears due to true pathology of the liver, hepatitis, cirrhosis, different toxic affection of liver due to poisoning, and growth of tumor. Let's see how will be changed bilirubin metabolism in this case. Erythrocyte destroyed usually, but unbound bilirubin cannot be completely transformed into the liver in bound bilirubin. A transformed bound bilirubin due to destruction of hepatocytes also mainly absorbed into the blood. As a result, blood overfilled with bilirubin when will be increased both its fraction, unbound and bound bilirubin. If the bound bilirubin absorbed into the blood, its less amount go through the gastrointestinal tract and mainly will be removed through the kidney. As a result, urine has specific brown color and becomes foamy. We are talking like beer urine. Urobilinogen, which is formed into the duodenum, also not come back into the liver because liver unable to transform it in bilirubin, it's completely absorbed into the blood and will be removed through the kidney. And only small portion of bound bilirubin go into the large intestine. As a result, feces of the patient will be pale due to deficiency of stecabilin. Our patient will complain of the problems which characteristic for any liver diseases. And we remember, if we'll ask the patient about color of urine and feces, urine will be dark and foamy, feces will be pale. On inspection, we reveal symptoms of liver diseases. Skin will be yellowish with specific reddish tip because long-standing process. Percussion and palpation help reveal hepatomegaly. And last, obstructive or mechanical jaundice, subhepatic jaundice, which appears due to obstruction of bile ducts, usually due to cholelithasis or canceromatous process to the pancreatic head, which obstructs common bile duct outside. Let's see how will be changed bilirubin metabolism in this case. Destruction of erythrocyte, usual vein, and activity of hepatocytes not change. But bound bilirubin cannot be evacuated with usual way through the gastrointestinal tract. All bound bilirubin absorbed into the blood. As a result, blood overreach with bound bilirubin, which water soluble and will be removed only through the kidney. Urine of the patient will be dark, foamy, feces colorless. We are talking about ekalia because transport of the bilirubin through the gastrointestinal tract stop. Patient complains of severe pain, hepatic colic if the source of obstruction bile duct, or progressive dull pain in right hypochondrium if the source of obstruction is canceromatous process in head of pancreas. We remember about ecolic feces and dark urine. On inspection, we'll see yellowish color of skin if the process long-standing in new growth of pancreas. Skin has slightly green or dark olive tint. Percussion and palpation reveal problem with gallbladder and pancreas. Will be positive gallbladder and pancreas symptoms. Sometimes both organs becomes palpable due to changing its structure. I'll again remember you main characteristic of every types of jaundice, which based on the analysis of blood, urine and feces. Hemolytic jaundice, blood overreach with unbound bilirubin, urine and feces dark due to increased level urobilinoid and species stecabilin. Parenchymatous jaundice, bound and unbound bilirubin in blood and proximately same. Feces becomes pale, urine dark due to increased level urobilinoid and bound bilirubin. And obstructive jaundice, blood overfilled with bound bilirubin, urine is overfilled with urobilin, feces colorless. Cholestasis syndrome is characterized with disturbance of synthesis, secretion, and outflow of bile. All process of bile formation. Usually, cholestasis syndrome has two origins, extra and intrahepatic. Extrahepatic due to cholestasis or canceromatous in pancreas head, and it's accompanied with obstructive jaundice. Intrahepatic appears patient with liver cirrhosis or progressive hepatitis, usually toxic hepatitis due to treatment with some hepatotoxic medicines. Patient complains of pronounced skin itching which intensifies by night because tightly correlated with activity vagus nerves, which activity increased during night period, accompanied with jaundice and dark urine and ecolic feces. Other words, you see signs of obstructive jaundice. On inspection, will reveal scratches on the skin and as a result disordered cholesterol and fat metabolism, we can reveal xanthelasma or xanthoma. Diagnosis may be established due to examination of alkaline phosphatase and bilirubin and cholesterol in blood. All will be increased. We'll obligatory send our patient on ultrasound examination, sometimes CT scan if you see seen about new growth, and sometimes needed a liver biopsy to establish a cause of disease, especially for patients with biliary liver cirrhosis. Long following cholestasis accompanied with disordered cholesterol metabolism. As a result, will be problem with accretion of bile and bile acid, problem with absorption of some microelements and vitamins, patient complaints of diarrhea and steatorrhea, feces becomes fatty, as problem with fat metabolism and deficiency of cholesterol and disturbance its metabolism, will be problem with liposoluble vitamins and some electrolytes. As a result, patient complains of night bleeding due to problem with vitamin A metabolism, osteomalacia, vitamin B, K, and predilection to bleeding because formation of coagulative function, and at last patient predilected to malabsorption and as a result weight loss, but itching due to progressive cholestasis, especially for the patient with progressive liver diseases, biliary liver cirrhosis. Next syndrome on which I want to stop is portal hypertension, which is increased pressure in the system of portal vein, which may be due to intrahepatic blocks, other word growth of connective tissue in the intralobular space of liver, which characteristic for liver cirrhosis. Maybe subhepatic block due to thrombosis of the portal vein and its branches. Usually it is characteristic for patients with abdominal tumor or enlarged lymph nodes or canceromatous metastasis, and suprahepatic block, hepatic vein occlusion, which is characteristic for Bardet-Chiari syndrome, but more often we'll meet patients with portal hypertension as complication of liver cirrhosis. It's more often origin portal hypertension. What are its main symptoms? First of all, if the blood cannot usually go along portal vein, it's go bypass. We are talking about formation portal-caval anastomosis. Difficult blood flow through the portal vein and increased pressure into the portal vein accompanied with absorption of the plasma into the abdominal cavity and formation of ascites. And we remember about tightly connection liver with spleen. Any problem with liver accompanied with immediate response of spleen, such as opposite correlation, splenomegaly. Three main symptoms of portal hypertension: formation of portal-caval anastomosis, and first of all manifested with formation hemorrhoidal venous plexus due to dilation of hemorrhoidal vein, esophageal gastric plexus due to dilation of esophageal and cardiac stomach vein, and paraumbilical vein system, formation of caput medusa due to formation of cava caval anastomosis. Ascites and splenomegaly. Let's see about clinical manifestation of all these symptoms. You see dilation of portal vein on abdominal wall. You see dilation of hemorrhoidal vein, which manifested with hemorrhoidal bleeding, and dilation of esophageal and stomach vein. Patient complaints on hemorrhagic syndrome, esophageal or hemorrhoidal bleeding, pain in left hypochondrium due to splenomegaly, and enlarged abdomen due to ascites. What can you see? We can see enlarged abdomen with protrude navel. We can see dilated vein on abdominal wall, caput medusa. Percussion and palpation helps reveal splenomegaly and ascites, and obligatory instrumental examination to reveal dilated vein of the esophagus and hemorrhoids, fibrogastroscopy and proctosigmoidoscopy, and ultrasonography for examination of spleen, and obligatory measurement diameter of splenic and portal vein. I'll again show you patient with esophagus bleeding due to rupture of dilated esophageal vein, which may be stopped only with specific Blackmer balloon. Patient with hemorrhoidal bleeding due to dilated hemorrhoidal vein. You see as significantly may enlarge spleen, and we see distant abdomen with visible dilated abdominal vein, caput medusa. Fibrogastroscopy reveals dilation of esophagus vein. Proctosigmoidoscopy dilated hemorrhoidal vein. Ultrasonography splenomegaly. Obligatory diameter of portal and splenic vein, and we can see liquid into the abdominal cavity. Same indices may be revealed with helping of CT scan. You see enlarged spleen, you see presence of liquid in abdominal cavity. I want to stop on principal diagnostic of ascites because this question will be given separately on exam. We remember patient come to you due to enlarged abdomen. On inspection, you can see enlarged abdomen with protrude navel and dilated vein if the cause of ascites is portal hypertension. On palpation will reveal fluctuation syndrome, which will ask you send on exam. During demonstration, you must remember your assistant must put palm on the linea alba to restrict activity of peritoneum and its abnormal movement, because principles of fluctuation syndrome, one hand of the doctor push on abdomen, other hand will feel vibration due to vibration of ascitic liquid. On percussion, we can reveal a level of the liquid into the abdomen. Obligatory will percussion abdominal on linea alba from xiphoid process downward before dull sound. In horizontal position from linea alba outside. And to check ascitic liquid is diffuse or restricted, will obligatory examine abdomen in horizontal position, then turn of the patient on side, and if level of liquid will be increased, it shows that liquid diffuse, or if not change, it shows that liquid restricted. It is needed to know for next manipulation, paracentesis. Will clear amount of liquid with ultrasonography or CT scan examination, and if the liquid resistant to action of diuretic medicines with use laparosynthesis, puncture abdominal cavity along linea alba with removing of liquid and its examination to clear cause of ascites. Hepatorenal syndrome. No, each name show you syndrome which is characterized with a simultaneous enlargement of liver and spleen, which appears patient with liver diseases, some blood diseases, some infectious diseases, poisoning with hepato or blood toxic substances, thrombosis of the hepatic vein, and some spleen diseases. Patient complains of discomfort or pain in both hypochondria and then symptoms which is characteristic for any disease about which I said to you. On inspection, we can reveal protrusion both right and left hypochondria. Percussion and palpation helps reveal both hepato and splenomegaly, which are obligatory because isolated may be only hepato or splenomegaly, but only they combined enlargement gives hepatorenal syndrome. And to clear our primary opinion, obligatory ultrasound or CT scan examination. I won't stop on next problem, hypersplenism, and pay your attention. Hypersplenism, which is increased functional activity of spleen. We remember spleen is depot of destroyed blood cells. As a result, it's characterized with pancytopenia, obligatory decreased level of red blood cells, white blood cells, and flatulency, and accompanied with splenomegaly. But to differentiate from any specific blood diseases, leukemia, which also can accompany with pancytopenia, will obligatory examine spleen and bone marrow. In bone marrow, all these elements will be increased to compensate pancytopenia in peripheral blood and accompanied with pancytopenia and splenomegaly. And last syndrome on which I want to stop today is hepatic insufficiency. When depending its time, distinguish on acute and chronic. Acute appears without preceded liver anamnesis due to action of hepatotropic substances, otherwise due to poisoning, maybe due to acute alcoholic intoxication or heavy virus hepatitis. Chronic hepatic insufficiency appears due to prolonged development of any liver diseases such as hepatitis, liver cirrhosis, or hepatocarcinoma. We said with you that any chronic insufficiency may be divided on 3 stages: early compensated, invisible, pronounced subcompensated, second stage, and last third stage, terminal or decompensated because involvement of other organs. I'll pay your attention on clinical signs of hepatic insufficiency. And first of all, we must remember liver is vital organ. Patient will die due to its self-intoxication. And first signs of hepatic insufficiency is signs of intoxication, on which first of all will respond central nervous system and will reveal signs of liver encephalopathy. Primary Patient cannot pay attention on these symptoms, and only attention of doctor helps reveals early signs of liver encephalopathy as symptoms of liver dysfunction or liver insufficiency. Problem with memory. Patient cannot concentrate his attention, and people's which activity, walking activity needed severe concentration of memory and attention only go to the doctor. And more easy test will ask the patient to write or to draw any figure, and patient writing and drawing will be changed. We can ask the patient name very fast number from 1 to 20 and come back, and patient with encephalopathy confused cannot continuously name you all numerals. Then we'll pay attention on progressive edematous syndrome because hypoproteinemia due to decreased activity of hepatocyte and decreased synthesis of protein. And hemorrhagic syndrome, again decreased activity of hepatocyte and decreased synthesis of coagulative factor. Progressive jaundice due to decreased activity or destruction hepatocyte in case of acute liver insufficiency in poisoning or acute hepatitis, and absorption of bilirubin and all hepatocyte substances and bile into the blood. I said you about stages of liver insufficiency. 3 stages. If we are talking about patients with liver cirrhosis, size of the liver progressively diminished due to growth of connective tissue and decreased amount of active hepatocyte. Patient with liver insufficiency died through the comatose period. First of all, brain go out, patient loses consciousness, and then finish with death. I'll remember you, patient with kidney and liver insufficiency died with unconscious condition due to intoxication. Let's stop on main clinical characteristic of different stage of chronic liver insufficiency. Early stage compensated, invisible, no clinical symptoms, and only specific test and attention of doctor on emotional sphere and behavior of patient helps reveal early signs of liver encephalopathy, and laboratory test will be on the high level of norm or slightly deviates from norm. Second, manifested subcompensated stage will be visible signs of liver dysfunction such as edema, progressive encephalopathy accompanied with finger clapping or tremor. Patient complains of weakness and decreased work capacity. We'll see that jaundice, ascites becomes uncontrolled and progressive due to progressive hyperproteinemia, hyperbilirubinemia, and dyspeptic disorders because liver is source of bile which needed for normal digestion into the duodenum. And final terminal stage manifested with deep metabolic disorders and obligatory involvement of surrounding organs. As a result, pronounced clinical manifestation. We see that patient progressively loses weight. We see progressive jaundice and edematous syndrome and progressive encephalopathy with disturbance consciousness. We are talking about pre-comatose period, which transform in deep depression of central nervous system, other word hepatic coma, and death of patient. Pre-comatose period manifested with progressive consciousness disorders. from inhibition or maybe abnormal excitation, but when the activity of central nervous system depressed, we see all stage of its depression: stupor, sopor, and coma. Patient becomes uncontrolled. We reveal pathological reflexes. If our patient with preceded liver cirrhosis, I said your size of the liver very quickly decreases, which is bad prognosis for the patient. I said you about progressive jaundice due to cytolysis, due to cholestasis, depending of cause of liver insufficiency. If acute, is usually cytolysis. If chronic, liver cirrhosis, cholestasis. Later, maybe increased body temperature due to intoxication, due to circulation of pathological toxic element into the blood, due to decreased immune response, and as a result spontaneous bacterial peritonitis. Will reveal pronounced edema. I said you first of all due to hypoalbuminemia, and then due to involvement surrounding organs, heart, liver, kidney, due to hemodynamic disturbances, due to decreased activity of the kidney. Will reveal progressive hemorrhagic syndrome due to decreased synthesis of fibrinogen, prothrombin, and due to abnormal activity of spleen, hypersplenism. Patient progressively loses weight due to hyperlipidemia and dyspepsia. You will understand if then a heavy condition of the patient, then more decreased appetite and activity of digestive enzymes. And patient died through the period of hepatic coma, which maybe provoked by first of all self-poisoning of the body due to delay of toxic substances, ammonia and phenol, due to disordered electrolyte metabolism, provoke factors maybe uncontrolled prescription of diuretic medicine to release edema, and ascites if the doctor forgot about its true mechanism. Coma provoked by taking alcohol, sedative medicine, because I said you first period may be uncontrolled excitation of patient, large dosage of diuretics, if the abnormal protein diet, because protein is very toxic for our organism without detoxification into the liver, and during this period must be restricted diet, must be corrected. Profuse hemorrhage also provoke factors of comatose stage, severe diarrhea, and accompanied infectious diseases, because you see all this process progresses metabolic disorders, water electrolyte, fat, protein metabolism. Comatose period characterized with motor anxiety, with formation of pathological reflexes such as sucking, grasping, accompanied with convulsion due to metabolic disorder, electrolyte disorder. Patient predilected to incontinence, defecation, and urination because no controlled central nervous system. His breathing becomes deep and loud, will be heard on distance. From the patient will be specific sweaty hepatic odor due to absorption of toxic substances through the mucus and respiratory system. For diagnosis, first of all, we'll pay attention on activity central nervous system, degree of encephalopathy, on edematous symptoms, manifestation and pronouncing of ascites, and laboratory tests. And first of all, we'll pay attention on level of bilirubin and protein, because hyperbilirubin, hypoalbuminemia, and coagulative indices, first of all prothrombin index, are main diagnostic criteria of liver insufficiency, which included in specific Child-Pugh scale. I tell you degree of encephalopathy, pronounces of ascites, level of bilirubin, albumin, and prothrombin index. In grave condition, due to involvement of other organs, we can reveal patients with liver insufficiency signs of kidney insufficiency. We are talking about hepatorenal syndrome, which characterized with progressive decreased glomerular filtration rate as result predilection to oligo and anuria, and increased level of creatinine and urea in blood. But there are primary functional disorders which independently can come back due to correlation of liver activity. That's all. Thank you so much for your attention. Be healthy, and we'll meet with you on next lectures. Goodbye.